Mr. Chairman, and thanks a lot to Dr. Katzenecker for introducing part of my talk. But so I have no financial disclosures, but I have a disclosure as well. And so I run a small program, as you may imagine, and small means approximately 170 transplants since 2006. So it's an average of about 13 per year with a range from below 10 to almost 20, and obviously a small surgical team. So what are my daily thoughts? And mostly it's all about envy. So I wish I were a big program. I wish big program is great, and a big program means a big team, and so big programs have the best results, et cetera, et cetera. And so obviously when I accepted this talk, this was my feeling, so I'm not going to make it at all. But I'm happy that most of the relevant papers were already presented and introduced, because I would like to go a little deeper into those papers, and so really look at what is the evidence out there about the relationship between volumes and outcome. I think this is really interesting. And look at the White paper. So this is like the most cited paper on the topic, defines high volumes as more than 20 transplants per year. So of course, mortality, either the low or long-term mortality decreases with growing volume. High volume centers have older recipients, more complex cases, more IPFs. But nevertheless, many centers, less than 20 transplants per year, perform well, and that is evidence as well. And also the authors themselves, look at the model they have used to interpret this data, and this C-statistics, which is an overall evaluation of the statistical model, scores 54%, which is kind of a poor predictive value of the model. And also the authors themselves at the end of the paper quote that if they were to decide, they would not consider any reason to close low volume centers. Let's keep on moving, and this is the Muni paper and study from US transplants between 2005 and 2011, covered by Medicare. So they exclude retransplants, multi-organ transplants, and so of course you've heard about reduced transplant cost, and this is due to a shorter ICU stay. Obviously we're talking about high volume centers, reduced early admission rate, et cetera, et cetera. But I'm glad my Vienna colleague showed just this first part of the figure, but there's something missing, okay? So look at that. These are just the easy cases, the low LAS, and there's the savings. There you can buy your mansion here. But if you go to more complex cases and you look at high LAS, then the balance gets quite even. So be careful when you interpret these huge cost advantages in high volume centers. And again, the authors themselves have a word of caution in general to the study, because they were analyzing just Medicare patients. So that's just a limited portion of all transplants. And they say that excessively high volume may need unavailable resources. So be careful. If you want to do too much, you might really hit the limit. And also, improved outcomes in high volume centers may not be only related to the increased number of patients. And also themselves, they would like not to consider closing small centers, because this may reduce competition and the beneficial effect of large centers. And we could keep going in looking into these papers and looking deeply into the meaning. And again, I'm happy my competitor cited this cystic fibrosis paper. So again, it's a US cohort. They were looking at the outcome in CF patients based on volumes. And actually, if you look very deep into this paper, the beneficial effect is not related to volume itself, but to the volume of these highly specialized and difficult cystic patients. So be careful. Again, the authors themselves pose a word of caution in generalizing the relationship between outcomes and volumes. And again, this is the Hayanga paper, was cited as well. And again, this paper has a C-statistics for volume in lung transplantation very low. So it's not a perfect model, and volume, according to the authors, is an imperfect surrogate for results. And again, many low volume centers have excellent results. And again, as cited by Conrad, this volume outcome relationship has been studied in many, many other papers on many, many other organ transplants. And this is just to quote one about cardiac transplantation. And again, the authors analyzed their outcome volumes relationships, and they quoted that there are many, many other factors that seem to correlate with outcome more consistently than volume. So such as age, recipient age, donor age, preoperative recipient clinical status, et cetera, et cetera. So it's very difficult to find a lower safety threshold for an appropriate volume. And always look, when you do these studies, at the statistical issues. Small centers can suffer really the play of a chance, so it's hard to interpret those statistics. So I'm gonna stop with a few conclusions here and at least some controversies from analyzing these papers. It's not so clear-cut that volume and outcomes have a linear direct effect, and these are the points that I would like to strike. Number one, metrics based just on volumes may not be completely reliable, and outcomes may be good in low volume centers as well, and this is evidence out there as well. The complexity of the case mix may play a key role, and remember this complexity word, and cautious interpretation of results from all centers should be taken into account where there's a high bias. Now, are there other factors, or is this the whole story? So I would like just to spend a few minutes and taking a closer look into a low volume program as ours is, and I'm gonna just look a little deeper into our case mix of historical 170 transplants, and it's a case mix predominantly made of IPFs and cystic fibrosis, so we're not really 70% emphysema patients. We have been doing mostly double lung transplants. We have a significant percentage of pediatric lung transplants, lobar transplants. We do ECMO, we do EVLP. So I think one of the items is really the case mix. And I think you should remember that going on into my talk. So number one, case mix. Number two, look at where you are. So look at your local hospital environment. It's not just your team, but what you have around in your hospital. So what happens at our place, we are at an actually University of Pittsburgh facility in Sicily. We're completely dedicated to organ transplantation and highly specialized surgery. We are fully JCI accredited. We are fully electronic, no paperless hospital. We run cardiac, thoracic, and abdominal surgical. We're a small hospital, and the overall number of transplants is 130, taking into account all the organs. And not only we should look at what we have around inside our hospital, but we should look at what we have around into our region. And again, here is us, a very small center compared to the northern giants, but this is the picture of donation in Italy, and look at how the country is divided between north and south in terms of donation rate, and how low this is going on, and how low donations are running into the south. So why are we running low volumes? This might be at least part of the explanation. And how do we perform? And again, this is critical. We have national outcome metrics from the government agency in Italy, 2002 to 2015, and you can see the general overall results of Italy, and you can see our outcome and our 1 year and 5 year Kaplan-Meier survival, which is consistently efficient and successful. And again, this is data as well, and it doesn't really change if you look at two more recent transplants, and these are the 1 year survival, and it doesn't really change if you look at a single year, the latest year available, and it doesn't even really change if you look at patient-adjusted Kaplan-Meier survival, and you can see our hospital is scoring 80% compared to 70% of the rest of the country. And let's go back to complexity. So these are a few examples of the complexity that we have been managing along these years, even if running in low volume environment. So number one example, this was the first lung transplant in an HIV positive patient. Patient is doing very well after 12 years. It opened up, promoting the update of clinical guidelines. It's not really surgical complexity, but is the complexity of putting together a protocol under surveillance of the central government agency to keep up with immunological and infectious disease management. And these were the complex treatment algorithm that we had to prepare for this case. Or we have been hearing about ECMO and preoperative ECMO in lung transplantation. And again, we have been doing more than 20% of our transplants on ECMO. And this is a lot more than what the large series out there present. And the numbers, the figures are that, centers performing 100 or more than 100 transplants per year actually have a rate of about 5 to 8% patients done after ECMO support. And even after ECMO support, our results have been pretty, acceptable, and there is no statistically significant difference between patients who were supported or not supported. And again, we have been using awake ECMO very, very liberally. Number three example, we have been setting up a protocol of using donors with multidrug-resistant colonization. And again, this is not a surgical challenge, but it's more of an organizational challenge in setting up a protocol where we can be safe enough that we recognize these donors, we individuate the bugs, and we set up a protocol for sampling, adequate communication, and treatment of these potentially unsafe donors. And last but not least, we have just had the approval of this monocentric trial for the use of HCV net positive donors for HCV negative recipients. So this is my second stop here, and I have further controversies to propose. So there are some hints that good results may not just be depending on volumes. And the role of complexity of care is one thing. Doing difficult things is hard, but may be possible and rewarding. The role of the setting, the hospital setting where you are, is very important. The role of logistics and geography may be important and condition the reason why you're doing a low volume or high volume, whether you're in a served or underserved area. And last, again, the role of the case mix. So did we get the whole picture? Is it just a matter of, doing complex things, even in a small setting? And I think the idea about lung transplantation and any big and large complex clinical activity is really to think in terms of quality of care. And it's not something that was invented. And this is a very nice paper from the New England Journal of Medicine entitled "Pledging to Eliminate Low Volume Surgery." And so this is a huge debate about, should volumes or outcome be measured? And this issue has been really debated for decades, and the authors, run the history about, outcomes versus volumes, et cetera, et cetera. And their conclusion is that both carry bias. And what we should really focus when we want to see if a program performs well or bad is to focus on processes of care. And what is this processes of care about? It's about multidisciplinarity when treating the patient and giving the patient enhanced attention. It's about nursing, not only surgeons and nursing protocols. It's about a culture of excellence, about clinical pathways, about electronic medical records, and the possibility to run quality control measures. And this is aided by simulation, by teaching, and obviously by clinical and preclinical research. And if you want to make an equation, get an equation out of this, and you want to plot a healthcare quality against volumes and complexity, I think healthcare quality runs really in this area, in these two boxes up here. And probably what you want to really avoid is low volume and low complexity, but also high volume with low complexity. My conclusion, big is beautiful, no doubt about that. I have nothing to say against that. Small is possibly feasible, but very difficult. Best formula may be volume plus complexity plus processes of care, and this may get us the best quality of care. But don't forget potential downsides of a big program, and also be careful because the metrics for quality of care still require a lot of work. Thank you for your attention.